Hey, good morning, everyone, and welcome to EuroNurse. We meet every Saturday at 9 a.m. Central Time. If you're watching us live, welcome to the show. Be sure to hit subscribe and hit like. This is your first time checking us out. Be sure to check out our website at euronurse.com, the best place to go to find out more about the show. And speaking of shows, we've got 92 episodes. You can see all of our past episodes always there on our website. Just go to the website, check them all out. Want to listen to us in the car? No problem. We've got our audio podcast. Just go to our EuroNurse Plus area and you'll be able to get a podcast on any of your favorite formats. Always there. Hey, and speaking of episodes, we have episode 100 coming up on June 29th. Be sure to join us on June 29th. It's going to be a special episode. I've got our experts that are going to be joining us, hopefully a couple of guests. Experts coming in, and we're going to have a drawing for some great prize for people to join. But you have to be there live, so start marking it on your calendar. And if you're a patient, be sure to check out our EuroPatient podcast at europatient.com. Follows this show at 10:30 every Saturday. Not getting our email? What are you waiting for? Check out us on our website. Register. Super simple. We use MailChimp, so your email is always safe. This week, I'm proud to have Dr. Garrett Pullman joining us. He's going to be talking about MRI-Guided Prostate Biopsy. So with that, let's go ahead and bring our experts onto the show. Experts, welcome to the show. How's everybody doing today?
Good morning.
All right. So we're going to do our intros ourselves just to let everybody know who's there. My name is Vic Sinise. I am the host and creator of EuroNurse. Been involved in urology for the last 40 years. And as most of you that are fans or watching the show on a regular basis know, I was away last week at South Carolina and went to see this really neat exhibit. It was the Yorktown. It's an aircraft carrier. They've got it now like a museum, and you can kind of walk around and see things. And I always try to find pictures that I think really kind of reflect urology. So this is the one I found. This was an aircraft carrier.
Of course.
It's also a good model for, reminding people get their digital rectal exams. With that, John, go ahead and introduce yourself.
Good morning. I am passionate about helping urology practices succeed so they can reach maximum clinical and financial efficiency. To that end, I created the Thriving Urology Practice Facebook group where we crowdsource practice management solutions for everyone's benefit. I frequently speak on topics of coding, billing, revenue cycle management, marketing, and how to run your practices more efficiently in the era of declining reimbursement and rising practice overhead costs. I just spoke at the AUA annual meeting in San Antonio last week and will be at the Texas Urological Society meeting in June, Louisiana Urological Society meeting in August, South Central Section AUA meeting in October, and the Urology Advanced Coding and Reimbursement Seminar in December. I'm John Lynn, a private practice urologist in Gilbert, Arizona, and I look forward to our discussion today about the exciting role of the in-office MRI in prostate cancer detection by our amazing Dr. Garrett Pullman. Back to you, Vic.
All right. Thanks, John. Hey, John, just showing off, how with the dual camera going?
Just a little bit.
All right. And Lori, go ahead and introduce yourself.
Hi, these are my angles.
And that looks good.
Hi, my name is Lori Atkinson. I'm a certified urology registered nurse. I've been in urology for 26 years now, and I currently work for a large urology practice in Geneva and Winfield, Illinois. So happy to be here. Welcome, Dr. Pullman.
It's good to be here. Andrea, you're muted, so be sure to unmute. There you go.
Thank you. Good morning. My name is Andrea Strong. I'm a nurse practitioner in Wisconsin in an academic center. I've been working in urology for about 14 years. I've done just about everything that there is to do in urology. I'm also certified as a urology registered nurse. I'm on the board of directors for the Society of Urologic Nurses and Associates, and I'm also the educational director for the Chicago Metro chapter, and I'm looking forward to Dr. Pullman's presentation today.
All right, great. And last but not least, our guest speaker, Dr. Garrett Pullman. Go ahead and introduce yourself, and then we'll take off with the show.
Well, thanks for having me on the show today, Vic. Again, Dr. Garrett Pullman. I'm a board certified urologist. I practice in Kearney, Nebraska at Kearney Urology Center, PC. Also host of the Prostate Health Podcast, and we're just came up and crossed the 100 episode barrier ourselves. And the Prostate Health Podcast focuses on conditions that affect the prostate, the latest technology in managing these conditions. So, for those even needing to dive in even deeper, I've created the Prostate Health Academy, which is packed full of in-depth lessons, resources, and a private community forum for Academy members. So I'm definitely excited to be here today and to talk on an enhanced prostate biopsy technique utilized in an office MRI-guided system, and can also be utilized in the surgery center and hospital setting as well.
Great. Let's bring on your slides and let you take away the show. There you go.
All righty. So here are my disclosures pertinent to this talk. I am an advisor for Promaxo, which Promaxo is developed a low-field MRI system utilized for targeting prostate lesions. So the American Cancer Society estimates that over 299,000 new cases of prostate cancer will be diagnosed in 2024. And over 35,000 deaths from prostate cancer is predicted, still the second most common cause of cancer death behind only lung cancer. And as urologists, our goal is to continue to better identify men who will benefit from treatment while avoiding overtreatment of men who are unlikely to benefit. So the classical pathway for the diagnosis of prostate cancer has been transrectal ultrasound biopsy of the prostate following an elevated PSA level. Studies have demonstrated the clinical value of a multiparametric prostate MRI and using this to guide biopsy decision-making, which can increase the likelihood of detecting clinically significant prostate cancer while lowering detection of insignificant disease. Now, our current AUA guidelines for the detection of prostate cancer state that urologists may use an MRI prior to the initial biopsy to increase detection of grade group 2 prostate cancer and perform targeted biopsies of the suspicious lesion, and may also perform systematic template biopsy. Now, it also states that urologists may use urine or serum biomarkers when further risk stratification would influence the decision regarding whether or not to proceed with a biopsy versus observing. So that was our AUA guidelines. So as far as current NCCN guidelines, for those individuals with an elevated PSA and or a very suspicious digital rectal exam, the guidelines recommend obtaining a multiparametric prostate MRI if available. But that's a big but. A negative MRI does not necessarily exclude the possibility of cancer, and that it is preferred to utilize an image-guided approach for the biopsy. And it also mentions that biomarkers could be considered to improve the specificity of screening. So some of the evidence behind the guideline recommendations include the Precision trial, which was a 500-patient randomized non-inferiority study comparing MRI-targeted biopsy versus systematic biopsy, detecting clinically significant cancer in biopsy-naive patients. Clinically significant cancer was detected in 38% undergoing the MRI-targeted biopsy versus 26% of patients undergoing a systematic biopsy. And patients undergoing an MRI-targeted biopsy also had fewer insignificant cancers detected at 9% compared to 22% for the systematic biopsy. And lastly, there was a significant uncontrolled variability, though, as there was no central reading of the MRI, which was performed at 25 centers in 11 countries. So biopsies were performed by either transrectal or transperineal route using cognitive or ultrasound fusion techniques. So definitely some variables there in this study. Now, a recent Swedish study looked at evaluating if a prostate MRI in biopsy-naive patients, those have never had a biopsy before, reduced unnecessary biopsies. Now, this was a retrospective population-based study including over 23,000 men who underwent PSA testing from 2011 to 2020. Now, what they found was after the implementation of prostate MRI and utilization of an MRI fusion guided biopsy, that fewer biopsies were performed, and then the odds of a Gleason 6 cancer detection decreased, whereas the odds of detecting Gleason 7 or higher cancer increased. Now, in an effort to capture the opinion of urologists toward employing MRI-targeted biopsy in their practices, this study utilized a questionnaire which was distributed and ultimately completed by close to 300 urologists in the US. And this was actually performed back in 2016, the questionnaire was. Now, the practice setting and geographic region were significantly associated with implementation of MRI-targeted biopsy, as 72% of urologists in academic centers reported using MRI fusion targeted biopsy compared to just 38% in solo private practice. And in the Northeast, 68% of urologists reported using MRI targeted biopsy compared to 44% in the Western United States. Now, I would assume these numbers have even further increased in terms of utilization since then, as urologists continue to support its use and are making further efforts to introduce MRI-targeted biopsy into their practice. So there are several methods currently in use for targeted prostate biopsy. I'd previously mentioned both the cognitive fusion biopsy as well as an MRI truss or ultrasound fusion biopsy, which can be performed either via transrectal approach or transperineal. There's certainly some advantages with a transperineal approach, most notably the less risk for infection at less than 1% for a transperineal approach. There has also been reported in-bore high-field MRI prostate biopsy, but with several important drawbacks, including significant upfront investment in MRI-compatible biopsy equipment and scheduling hassles trying to do these in radiology, just not very conducive for the busy urologist. Now, just recently, a compact low-field open MRI system became available, allowing urologists the capability to perform these biopsies in the office or the surgery center. So in March of 2021, the FDA granted Promaxo 510(k) clearance for an office-based open configuration MRI system. Now, this was intended to be used for targeting prostate lesions under MRI guidance and is now commercially available. So it's really the first of its kind. It's a single-sided, low-field MRI system at 0.065 Tesla compared to our 1.5 to 3 Tesla MRIs that we do to get the initial MRI. So the low-field MRI system, it's got the open design to accommodate really patients of all sizes. Now, how it works is regions of interest from previously obtained high-field MRI images, that's your 3 Tesla, your 1.5 Tesla MRI, they're first obtained and mapped out. Then the low-field MRI system is then used to localize the suspicious lesions and obtain the location or coordinates of each target within the prostate. And they're still using the high-field images to do the localization. And then using a fixed grid template, the prostate biopsies are taken through the perineum without the need for a rectal probe. Again, after those, the high-field and the low-field images have been brought together. So certainly there were some potential advantages that were intriguing for us with this system. So we were previously performing MRI fusion transrectal biopsies in the hospital setting. And for us, it was more of an inefficient process, looking at an hour or more per biopsy when you're accounting for OR turnover at the hospital, but also for reimbursement for performing MRI fusion biopsies in the hospital was not very favorable considering the time involved. So I'm always looking at ways of bringing more procedures into the office setting or the ASC setting where we can be more efficient, as well as allowing the opportunity to see more other patients in between biopsies and setup. There's also of course, the advantage of the transperineal approach with this method as well, with less risk of infection compared to transrectal. And patients also appreciate not having a probe in the rectum. We also like the idea of utilizing a different registration process. So rather than using 2 different modalities with the fusion process, taking a three-dimensional MRI, trying to put that together with a two-dimensional ultrasound, now being able to register an MRI with an MRI. So also with the ultrasound-guided fusion system, you can get some prostate gland deformation as you're pushing up on that prostate with a transrectal probe. Where again, with the low-field MRI system, with no rectal probe, there's no kind of gland deformation of the shape of that prostate. There are also some different codes when it comes to using this system, now incorporating several MRI codes as well. So the system can be used in the hospital and surgery center, but it can also be employed in the office setting. For our practice, it just made the most sense, and we had space for it, for us to bring it into the clinic. I believe the minimum requirements in the clinic setting are a 10 by 10 foot room. Our room is a 10 by 12 foot room. We just added a 220 volt plug and we were up and running basically. From a workflow standpoint, it's been pretty seamless in the clinic setting, and I can be efficient. I am able to see other patients while they're performing the MRI scan and registration process, and I'm able to pop back in and take the biopsies, which take around 8 to 10 minutes. We're right about 25 to 30 minutes wheels in to wheels out with these procedures, and continue to try to be more efficient as we get further into this. So again, here's an outline of the workflow. So to clarify, the patient still does need the initial high-field 1.5 to 3 Tesla MRI. This does not replace that initial MRI. That MRI identifies the suspicious region or regions of interest, gives you your PIRADS classification. Then the system acquires the images from the high-field MRI, and the regions of interest are mapped out by a centralized board-certified radiologist. The annotated images are already preloaded prior to the procedure date. For the procedure, patients are then placed in a high lithotomy position with their perineum close to the center of the low-field MRI with a transperineal template placed on the perineum. The MRI system is then used to localize the regions of interest and obtain the coordinates of each target within the prostate. Then using a fixed grid template, prostate biopsies are taken through the perineum. Now, depending on if you position this in your clinic setting or your surgery center, will often play into the choice of anesthesia as well. For those being done in the ASC, it just makes sense to use some IV sedation where anesthesia is always readily available. In the office setting, there are multiple options based on surgeon preference and comfort level. There are some users that prefer a combination of Valium and local anesthetic. I've not personally tried this combination yet. So far, we've tried Pronox with local, but we've also brought in anesthesia to perform IV sedation. So in terms of in-office sedation, I think this will be somewhat region-specific. And if there are any particular regulations in your area or in your state for in-office anesthesia, as well as anesthesia availability for you. But both have worked well for us in our office setting. With initial cancer detection rates reported at 71%, obviously larger scale studies will continue to help further validate and compare this new modality with both traditional and fusion-based approaches. Now, it's also opened the door for us in terms of targeted in-office focal therapy for appropriate candidates. So far, our practice has identified prostate cryotherapy as a modality that can be utilized in the office setting. With a combination of local and IV sedation, we began performing our in-office prostate cryoablation and focal therapy in December of 2023. And we utilized the tabletop Boston Scientific IceFX system, which only requires argon gas. And it really worked pretty slick to do this in the office. Patients did very well. We had Wasatch company and technician bring in the equipment for the cryoablation. We're also exploring the CLS laser system as another potential viable modality that can be performed in the clinic setting for targeted focal therapy. HIFU and NanoKnife will not likely be doable in the office setting, but rather in the ASC or hospital setting when looking at focal therapy, and could also be potentially brought in and utilized with this system as well. So in conclusion, the technology and technique continue to evolve as urologists strive to better identify men who will benefit from treatment while avoiding overtreatment of men who are unlikely to benefit. And urologists will need to continue to champion the development and implementation of this new technology. Now that concludes our talk regarding the secrets of MRI-guided prostate biopsy. I'd welcome you all to check out my prostate health podcast. You can subscribe to the show through the podcast app on your iPhone or Android device. We also are on Spotify and pretty much most other outlets you can find podcasts. You can also find episodes on my website, prostatehealthpodcast.com. And lastly, I'm excited to announce that the Prostate Health Academy is also open and has been launched. The Academy has multiple features, including bonus content from the Prostate Health Podcast. Really a critical component of the Academy is providing a private community forum moderated by myself where you can connect with like-minded individuals within the group. This is really more of kind of a patient-centered academy. There are also comprehensive lessons covering information on prostate cancer, BPH, prostatitis, and I've also included essential information on prostate diet and exercise. So for those interested, just simply sign up at prostatehealthacademy.com. I'll be in there every day interacting with members and to sign up and begin taking advantage of the Academy. But thank you so much for your time and your attention today. And I think we'll go ahead and Vic will open us up for questions now.
Yeah, that was excellent. Great presentation. Just gonna move my board around here a bit. So I was interested at the very end where you're talking about that you're opening something out that I think reaches out to patients with that Health Academy. And we had actually found the same thing with UroNurse, that a lot of patients are viewing this because they've got questions, they want answers, they want to learn more about urology. And so I actually started the UroPatient podcast as the same type of thing, a way to reach out directly to patients with more patient specific. So I think it's great. As we probably both know from doing it, it's a lot of work. Patients do have questions, but it is always a good thing. For those of you that are watching on the live audience, feel free to put all your questions in. We'll be glad to take those. So I was going to get kicked off with the questions. As far as anesthesia, we do a lot of Pronox and local for our current prostate biopsies with traditional ultrasound. Which did you find better to use in the office? The Pronox, Valium? Do you have a preference?
You know, I think they both worked well. I think right now we're sticking with the IV sedation because we're now set up to utilize it for targeted focal therapy. And, I thought initially maybe that would slow us down to have anesthesia in there and putting the patients to sleep. But it actually, I think it's been just as efficient, if not more, because sometimes, as you know, with the Pronox, depending on how much those guys are really huffing in on it, sometimes they can kind of, it kind of takes a little bit for them to come out of it as well. So now we just kind of slide them over to onto the cart. We can safely take them over to our recovery area and start getting set up for the next case. And patients really do like it. The one thing I noticed with the Pronox is, for most patients it works well, and your block works well. But there's been some occasional patients that are kind of wiggling around a little, just a little uncomfortable, and you kind of have to be a little more, a little more ginger there and make sure that they are having a good experience. So I would say right now, that could change in the future, but our personal preference, just because we have it available, is just to do the IV sedation with anesthesia.
If I can interject here real quick.
Yeah.
Not every state allows in-office IV sedation. So that's something to keep in mind because the audience is worldwide here and probably most in the US. You have to check with your state regs whether or not you can provide IV sedation in the office. Secondly, Pronox has a 50-50 mix of oxygen and nitrous oxide. There are other machines out there, for instance, Nitronox Plus. One of their models has an adjustable nitrous component. So you can dial it all the way up to 70% or minimally, I think 10, 20%. That's adjustable, which may be of benefit for those who want to use nitrous oxide in your office. So that's called Nitronox Plus.
Thanks for bringing that up, John.
I'm going to have one more question on the local anesthetic. Are you using the MRI guidance are you just using local to the skin, or are you using the MRI to guide prostate block?
No, just we're not utilizing the MRI to guide the block. So, I mean, you could do that one of two ways. I'm using more anatomic landmarks. Initially, for the local aspect of it, when we were doing the Pronox and for those also combining it with Valium without Pronox, I use a little kind of a lidocaine spray in the skin just to kind of numb up that skin. And then I'll do just a little sub-Q local underneath the skin. And then I'll do a deeper prostate block on both sides of the prostate along the neurovascular bundles. I know some urologists will put an ultrasound probe in to facilitate, giving the local, but we've had pretty good luck just with the anatomic landmarks and making sure that we kind of get it in the region of the nerves.
Good. Lori, do we have any questions coming from the audience? I'll let you be our monitor for that.
Sure. So, Nancy says, great for the office. What prep do you do prior to the biopsy? Do you do Cipro, targeted antibiotic prophylaxis with rectal swab, others, or do you do fleet edemas?
So since we're doing this now, this technique is transperineal with the, infection risk very, very low, less than 1%. We just do the oral antibiotic, and actually there's some that will argue that do we even need an antibiotic with the transperineal approach? So, so we don't have to. There's no swabbing or any of that going on with the transperineal biopsy, which is nice.
Good. Andrea, any questions for Dr. Garrett?
Yes. Thank you so much for that presentation. I don't do the biopsies in clinic, so I was really excited to learn more about it. I have a question, two parts. First, can you review the PI-RADS scoring system for our audience? Yeah. Second question is, let's say you have a patient with a PI-RAD 5 lesion, biopsy is negative, now what?
Good questions. Well, first of all, the PI-RADS classification for our patient listeners out there is a classification system that the radiologists utilize, and we of course utilize it as well once we get that information back on the scoring of it. But it allows us to classify the lesion in terms of how suspicious that lesion is. So that scoring system goes from 1 to 5, and the 1s and 2s are not very suspicious for clinically significant prostate cancer. 4s and 5s are more suspicious, and then the 3s is what we kind of consider more of an indeterminate or we're not quite sure. It's kind of in the middle type of a classification. So when we're talking about doing the biopsies, we would not be trying to target a PI-RADS 1 or a 2 lesion, maybe not even a 3, depending on which urologist you talk to. I kind of take it for those PI-RADS 3 lesions. I'll discuss that with the patient, and obviously I want to look at the images myself. And if I feel that there is something there that we can target, and we're going to be doing a biopsy anyways, some patients will elect to go ahead and to do some targeted biopsies, even if it's a PI-RADS 3. But definitely for a PI-RADS 4 and 5 lesion, those are the ones that you're going to target. Now, when we do the targeting, it depends on how big that lesion is. If it's a 3 or 4, it's a centimeter lesion. It's a bigger area. We may take 4 or 5 biopsies, maybe more of that target, and for a smaller lesion, maybe 2 to 3 biopsies. Now, I still take some biopsies outside of the region of interest. I think we're getting better and better. Our radiologists are in identifying these lesions, but I have seen it in the past, and this was more when we were doing the transrectal ultrasound approach, and maybe that was part of it too, where some of the all the targets came back negative. Those biopsies showed no cancer, but some of our more what we consider more random or outside of that region did show some prostate cancer. The question about the PI-RADS 5 lesion that came back without cancer. So again, kind of situation specific, and each situation is a little bit different. But one consideration was, did we not hit that lesion with our approach? And you have to kind of look back at your technology and how confident you were in hitting that area. I know with some of the fusion technologies, it's almost like we're having to shift the picture to make it actually fit onto it. So it makes you kind of wonder, some of the accuracy of how that's being done. But again, I think it's getting better and better, all of the technologies in identifying cancer. But, that's a patient where I would not want to forget about that patient. I would want very close follow-up for a patient that had a PIRADS 5 lesion, which was negative. And that's where also some biomarkers, biomarkers will come in place. I recently had a patient that very same situation, based on insurance, he was not able to do the in-office MRI to MRI. This was more of a fusion biopsy, but his biopsies were negative. It was a PIRADS 5 lesions, about 1.5 to 2 centimeters in size. So it's a big enough size. I'm confident we were likely able to kind of hit that area with our 4 to 5 biopsies. But interestingly, his biomarker, I'm utilizing a very highly accurate biomarker called EpiSwitch PSC. That came back low probability. And so that was one choice that, when counseling the patient, I said, hey, look, we have a biomarker here that says low probability, but we have a PIRADS 5 lesion. It was kind of a tough call. And do you go with the biomarker or do you go with the MRI? Well, his biomarker was low probability, and maybe that PIRADS 5 classification, maybe that really isn't significant prostate cancer there. But regardless, I think this is a patient that you'd want to continue to keep a close eye on, and have them back in very least 6 months, check another PSA, and likely even another MRI in a year from now, depending on what his PSA is doing, and possibly consider a repeat biopsy at some point.
We have to keep in mind. Go ahead.
I just wanted to ask if that biomarker was a urine test or a blood test?
A blood test. Yeah.
Okay. Thank you.
Mm-hmm. And John?
I was going to say, we have to keep in mind that even with the high field MRI of the prostate, it still misses 3 to 10% of prostate cancer. Yep. So just because the MRI of the prostate is okay, low PIRADS or minimal risk, doesn't mean that the patient has no prostate cancer. So always keep in mind that no study is perfect. And like Dr. Pullman said, registration, try to match the images from the high field and the low field and try to do the biopsy is not perfect either. So when you have a bunch of imperfect systems set up, got to be careful of confirmation bias. You can't just say, oh, MRI is normal, no PIRADS, no significant PIRADS found. You can just kind of ignore things. What Dr. Pullman is doing with using multiple approaches, the EpiSource, PSC, and all that stuff, that is really important. And also looking at the patient, looking at everything else that's going on with the patient, and not just MRI is normal or MRI is abnormal. We are going to proceed that way.
Yeah, and I totally agree. I mean, I think there are some urologists out there that they 100% rely on MRI in terms of whether or not they get a biopsy. And I've certainly diagnosed significant, Gleason 7 or higher prostate cancer with a normal MRI. So again, you got to look at the complete picture of the entire patient, counsel that patient on the risks and benefits, and kind of help guide them along that decision-making process.
Now I know you're doing this for positive MRI results. Are you able to do this just as a peritoneal biopsy with MRI guidance on somebody with a negative MRI? There's nothing there except you want to do random biopsies, or targeted biopsies.
Yeah, I don't see why you couldn't be able to do that. We have not started to employ that yet, but and that's where we're still doing the ultrasound systematic biopsy. That can also be done from a transperineal approach now as well. But I don't think there's any reason why you couldn't use that, the MRI that they've had to kind of map out where the prostate is, because the software is pretty intuitive. You just, right before you take the biopsy, you pick out where you want to take the biopsies, and exactly the coordinates, the distances, where you need to take the biopsy. And it's kind of like the system is cool, and it's almost like, like a Tesla, it's constantly being updated, and, the registration process keeps getting, it has gotten even quicker. But also it's not FDA approved yet, but they're currently in, upcoming approval as a robotic arm that actually takes the biopsies and takes them off puts them onto the specimen prep pad for you. And also that system, we can also, in the future would be able to also use that for targeted focal therapy and also real-time monitoring of the ice ball and for cryotherapy. So it's just, I think technology is awesome. And I think that, every year, whether that's for BPH or for prostate cancer, it seems like we always have new technology coming down the pipeline that can help patient care and help urologists in delivering that care and help patients in the long run.
Oh, thanks. Because, patients are even if you say, well, the risk of a prostate biopsy sepsis is 3%. If you're that person who gets sepsis, it's 100%. Yeah. So I'm always looking at, at being eventually probably maybe a consumer myself. What would I do? So I'm always interested in, what's the best attempt. Good. Yeah. Any other questions coming in from the audience? The audience is quieted today. Feel free to put those questions in, folks. Experts.
Being empathetic to the patient is you can't go wrong with that. And utilizing available technologies now to avoid unnecessary biopsies is key. I remember at the drop of a hat back in the day during training, we biopsied everybody. And if you had an initial biopsy showing no cancer and your PSA is still high, we repeated your biopsy in 3 to 4 months, inducing a lot of potential risk to the patient. Thankfully, technology has improved. We have all sorts of biomarkers and genomic tests that we can perform, even on that biopsy that show no cancer. So to minimize the need for a repeat biopsy. And this in-office low-field MRI is just another iteration in this process to do a better biopsy.
Yep. Nancy had a question regarding any issues with insurance coverage.
Yeah. So, being one of the first to market with any new technology, you kind of have to lead the, kind of carry the flag and lead the charge when it comes to insurance. And I've kind of been the one to have to do that in our area for multiple technologies. And it was no different with this approach. And so, surprisingly, Medicare was one that initially was giving us difficulty, and we're kind of working through that process as well. So it's we have had it covered by many of our private carriers, our VA carrier in the area, and so but it's again just one of those things that it's not 100% covered, and that's why you need to kind of do your due diligence and making sure that you get the prior authorizations and make sure that before you move forward with this. So.
Yeah, there are always 3 things that I think about when it comes to newer technology in medicine in general. Number 1, is it clinically efficacious? And number 2, is it legal? So legally, is it okay to do? And lastly, is financial. And unfortunately, if there's no reimbursement or minimal reimbursement, or there's a lot of hurdles or friction for the practice to adopt that technology due to financial concerns, then that technology is going to be harder to be used in real life, in practice.
Yeah. And I think the patients have really appreciated being able to do this technology in the office. It's less cost to them, than than having to do it at the hospital. Yep. But also, from a urologist perspective, our overhead continues to go up, and to be able to have this in the office setting, better reimbursement than being able to do it in the hospital I think it's been a win-win.
Do you have to buy the machine yourself, or is this something you rent?
You can buy the machine, but they have kind of a rental basis, a per click basis, and so yeah, we did not buy the technology, and that's the nice thing too. Is your practice can test it out, try it for 10 cases. If it's not going to work for your setup or for your flow, then they can come and take it right back. So.
Can you tell us a little bit about your practice setting? Is it hospital affiliated, completely private practice, and how many docs and APPs?
So where we're at is kind of rural Nebraska. We're about 4.5 hours east of Denver on Interstate 80, and you go another 3 hours and you're to Omaha. So we kind of service that middle corridor all the way up to South Dakota, and we see patients down into Kansas as well that come up to see us. We're a private practice. In our community, there's 2 hospitals, and we we do cases at both hospitals. That we have a surgery center that we do cases at, but our clinic is strictly private practice. We're kind of a 3-man group. Currently, we don't have any APPs, but that will likely change as our patient volume continues to increase. And as you know, everybody's recruiting to try to get urologists to come to their practice. So we're currently in recruitment. We have a couple of our older partners that are looking to retire. So that's kind of the makeup of our practice. I enjoy being private practice, being able to, I think it's made it a little bit easier and kind of trying to implement some of these newer technologies and having a little bit more autonomy with some of the decision making in our practice.
I love having the ability to pivot extremely quickly. So I've been, for instance, I talked to some of my colleagues locally here who are in larger groups, and they have been purchased by private equity to implement laughing gas, nitrous oxide in their practice. It's been a hurdle because there's so many layers of bureaucracy. And I actually have been trying, I have had Pronox for a while. For the last 6 months or so, I've been using Nitronox Plus, trying a different technology. And I saw something, it's interesting, this story. I did a video about Nitronox and Pronox, and then somebody saw it, DM me via YouTube, and that's how I ended up with this machine, checking it out. So being flexible, being able to pivot quickly in private practice, there's no comparison. The other thing that I noticed with your practice, now that you mention it, for a small practice, it's even feasible for a small practice to use Promaxo. So that's very telling.
Yeah, I mean, and that's the nice thing with being able to not have to come up with it may make more sense for a lug pud type group to buy the machine, depending on what their volume is. But to be able to rent the machine and even works out for a 2 to 3 man group has been awesome. To get this technology out there for patients.
Yeah, and in semi-rural area, even though your catchment area is quite large, but even for relatively, not a metropolitan area.
Yeah, and for those practices considering to utilize this practice, I mean, the company's been great to work with. They send out a technician. We try to group our cases, so we do maybe 1 or 2 days a month of these, depending on how many biopsies we got that are needed. But currently the setup is where they send out a technician that helps get the equipment up and going and kind of helps with the registration process. But I could certainly see it much like the Da Vinci and Intuitive, where at some point once you're kind of up and going and you kind of have a feel for the system, that they could field any questions remotely and your team could kind of take over running this equipment.
How many people do you really need in the room to do this? And what degrees, what is their education?
Yeah. So really, the only, I just have one MA that helps out with the procedure. She helped, it's kind of a team effort. The Promaxo rep is kind of running the machine and doing all of that. And then my MA just kind of helps with, getting the patient prepped and ready. And we talk about efficiency in private practice too. Off of Amazon, I bought about 2 little like $30 buzzers. It's almost like you're in a restaurant, but so I give the button to the Promaxo rep, and when they're ready for us, they hit a button and we both, our buzzers vibrate. So we're in there in like a minute. So I don't have to be popping my head back in looking to see if they're ready or not. When they need me, they'll let me know, and then I'll come in to do the biopsy after the registration. And I think it just helps with efficiency. To just implement even simple things like a little buzzer. It's funny, our girls, they went ahead and put one of the buzzers on my partner in clinic. So if he's in his office, doing notes or whatever, and he's got a patient ready, they'll just buzz him now. And so it helps in other areas too.
Yeah, we've actually all carry iPhones and have the Apple Watch. And we use the text messaging constantly, ready for you in, room 4. It really, as you say, an efficiency thing is huge because it's kind of not obstruct. Patients don't think you're looking at a phone or something. You just kind of glance at your watch and you see that you've got something going on. So it is neat how technology does come into play. With the Amazon buzzer.
Yeah, I'll shoot you a link. It's that is the nice thing too, is that you just kind of clip it on your scrub pant, and you're not having to look at your phone or anything, and it works pretty good too. So it's another option to think about.
Well, this has really been great. I don't know if there's any other questions. Experts, any questions from you guys? This is your last chance.
I just had a comment for all of our listeners. I know there's always a lot of questions about what antibiotic is best to prevent infection, and there's different protocols for that. There is a local antibiogram that's available to anyone, and it's usually through your infectious disease department. It's basically a graph, like usually a one-page graph that shows you the resistant rates of antibiotics in your region. So we do use that in our practice. We have low levels of resistance to intramuscular Rocephin. So that tends to be our go-to. Of course, the more we use that, we'll be building resistance for that as well. But I just want everyone to be aware that your local antibiogram is a great resource.
Absolutely. Good point.
You can get that through your hospital, your local hospital.
Yeah, thank you for that.
We're going to put a plug in for next week's show. Next week.
Pelvic pain can be a distressing and disruptive condition, affecting individuals of all ages and genders. It manifests as discomfort or agony in the lower abdomen, pelvic region, or genital area, and can arise from various underlying causes. Endometriosis, pelvic inflammatory disease, urinary tract infections, irritable bowel syndrome, and musculoskeletal issues are among the common culprits. Uro nurse expert Lori Atkinson, RN, Kern will guide us through a comprehensive understanding of pelvic pain and its multifaceted nature. Join us next week on Uro Nurse.
All right. So, Lori, we'll see you next week as our expert presenter. Looking forward to that. I did see one comment come in just as I clicked over here. Don't want to miss that one. Tabo said, my hope is my clinic will one day consider using this new technology and great presentation. So I did want to bring that up.
Yeah. Thank you.
But again, Garrett, thanks. That was a great presentation. Really appreciated it. I think that it's just, like I said, we can't, it's so nice to be able to bring in all this new technology and find speakers to talk about it, because it's hard to keep up otherwise. And this has been a great format for me to learn more and continue to learn. I think it's great for everybody else. So with that, I'm going to go ahead and call it a day and have a nice weekend. And we got beautiful weather by me. I hope it's nice by you guys, and enjoy your rest of your day off if you're off. Otherwise, we'll see you next week at Uro Nurse.
Thank you.
Bye.
Bye.
Thank you. Bye.